Thank you, Stephen. Thanks to the rest of the CRE for inviting me to talk about what I think is a really important topic in asthma, severe asthma, and it's covering the children. So my talk today, I'll just be giving, first of all, an overview of severe asthma in pediatrics. And then I've broken down some management issues along with some studies to highlight those issues in the different age groups that we see. So preschool age kids from 2 to 5 years of age, school age kids, which we classify from 6 to 11, and then the adolescents, which really goes up into young adult. And then we'll go through some severe asthma treatment options for children. So just risk factors for severe life-threatening childhood asthma events and childhood deaths, because obviously that's something we want to avoid or prevent where possible. So this is the ERS ATS guidelines on severe asthma. Their definition is that asthma that remains uncontrolled despite the highest recommended level of inhaled medication or maintenance oral corticosteroids, or that requires such treatment to prevent becoming uncontrolled, is the definition of severe asthma. And based on this definition, as a respiratory pediatrician, I do get referred a good few patients who meet this criteria, but actually when you dig down deeper and investigate a little bit more and question more, the actual number who reach those criteria is actually only a handful really each year. And that's one of the roles, I guess, of a respiratory pediatrician is to do that digging and looking for alternatives and seeing can you wean down medications, because the number of children who have severe asthma really is quite small. And the treatments associated with asthma and required to maintain asthma control do have side effects, both in the long term and in the short term. And asthma itself in children, it can have repercussions not just on the health of the child, but obviously on their school attendance, their sporting activities, their social interaction, their education. So it is important to get the diagnosis correct and to manage it appropriately. So this is from the National Asthma Council, the recent, the recent updates to the asthma handbook, which were just released last month. And you can see on the left here we have they're quite clear to indicate how many, so the width of each step is meant to indicate how many patients step. So in children, although we don't really have accurate data because short-acting beta agonists are available over the counter, we don't know how many children in Australia with asthma are managed only on just a short-acting beta agonist as required, but we suspect it's the majority. A smaller number require a low dose of inhaled corticosteroid or a montelukast. And then as you move up, the numbers become smaller, and this is really where the recommendation is to consider referral to see, you know, if a child isn't maintained on a low dose inhaled corticosteroid or montelukast, is this really asthma or is there something else going on? And finally, when you get to step 4, really these children do need referral on, because the specialized treatments in children can only be prescribed by a specialist. This is the asthma toolkit. So if anyone hasn't made their way to it yet, it's definitely worthwhile. And you can see the pediatric section down here in the bottom. So this is really for children, or for anyone, I guess, with more severe asthma. So the handbook helps with asthma management guidelines up until a certain level, and then it suggests referring on. So if you're the person that's having children referred on, this is a good resource to have and to familiarize yourself with. with regards to guidelines on how to manage children with more severe asthma. In the overview section, there's, quite simple stepwise guidelines, which everyone knows they're not difficult. Going through them, first of all, you review really asthma. Does it mean that this sound like a default diagnosis? Does the child, and from the age of 5 to 6 years, they should be doing lung function and including bronchodilator response. Objective measurements support your clinical diagnosis of asthma. In younger children, they have difficulty with geometry, so you don't have that luxury. Step 2 then is assessing for comorbidities. So like, is dysfunction or vocal cord dysfunction or allergic rhinitis or anxiety contributing to poor asthma control? Or perhaps is there a completely alternative diagnosis? Do they have asthma plus something else like tracheomalacia, or perhaps it's not even asthma at all? Perhaps there was a foreign body inhaled a few years in, causing symptoms of cough and wheeze, localized wheeze, and yet it hasn't really been fully explored. Step 3 then is assessing inhaler technique. It's really basic stuff. Advice, spacer where required. Do they need to use a mask? Or if they're that little bit older, perhaps getting rid of the mask. So you're actually improving the deposition of the medication within their lungs. It's not getting filtered through the nose. There are websites such as the National Asthma Council and Asthma Australia, which have videos where you can look up and you can direct families to check inhaler technique. Exploring adherence is always important, and it's not just a case of did you take your medications, did you remember to take it, but really exploring not only but when they take it and how they take it and how frequently they remember, how frequently they forget, but also exploring the barriers to that. And as part of that, you can sometimes use a monitoring device to see how frequently are people adhering to their prescribed regimen. So this is a study that was published in 2014 in the European Respiratory Journal. And the actual title of the paper is, it's the adherence stupid. So someone obviously has a marketing degree, but what they did was, it was in the Netherlands, in preschool aged children, they had electronically monitored devices for their inhaled corticosteroid. And all these children were already attending what they call a comprehensive asthma care clinic, where their inhaler technique was monitored. They were assessed for allergens and exposures. They had asthma education, and they even had a home visit. So these children were really being cared for quite well. But the treating staff, so the staff who were treating the asthma, were blinded to the adherence rates, which were being downloaded every 3 months. And in this study, surprisingly, well, I guess surprisingly was the adherence rate. So over 50% of the preschool age children had 80 to 100% adherence over 12 months. They're inhaled. Very few weren't taking their steroid at all. The numbers immediately increased. Here on the right, you can see in column A is those who had well-controlled asthma. Mostly well-controlled is white, lighter grey is mild, uncontrolled, and then the very light grey is uncontrolled. So there was a number who had uncontrolled asthma despite excellent adherence. So it's certainly not the only problem when it comes to asthma in children. Sometimes they are adherent and they still have severe asthma. In order to exclude those patients who were perhaps poorly adherent with their inhaled corticosteroid because they didn't really need it. They did look in column B at those patients who were still on an inhaled corticosteroid 2 years later, and those who had asthma were more taking their inhaler regularly, whereas those with asthma and mostly well-controlled asthma were less likely to be adherent. Include assessors and exposures. And identifying tobacco exposure in the home should always be accompanied with a discussion around that with the parents or the family members around where are they at with regards to considering cessation. Do they want more information on how their smoking may be affecting their child's asthma? Would they like access to support services, and encouraging them to sort of follow that path. Allergen exposure and considering allergy testing is also important when it comes to childhood asthma, because obviously if it's difficult to control the asthma if they're constantly being exposed to allergens. Step 5 is monitoring for side effects. So as I mentioned at the start, a lot of asthma treatments, really all asthma treatments, have some side effects. The ones we are particularly concerned with are this in both oral and inhaled corticosteroid side effects. And in children, we really need to think about growth, which isn't so much of a problem, I guess, as you get that little bit older into adulthood. Whereas children, the only time that they have to grow is during childhood, high growth. And if inhaled corticosteroids or oral corticosteroids are going to impact that, it will have long-term consequences. And Montelukast obviously is the neuropsychiatric side effects. So parents should always be warned about those and advised what to watch out for. Consider a home visit, and this allows staff, whether it's the community nurse or the nurse asthma specialist, to go out to the home, look at, does everyone know where the medications are? Are they set where they thought they would be? Are they in date? Are their spaces available? Are they clean? What are allergens like and other exposures? Is there open fires? Is there a lot of construction nearby? And is there a psychosocial stresses in the home that may also be contributing to poor asthma control? Step 7 then is additional treatment options. So looking at the preventer therapies that the child is on, is there alternative devices that might suit them better? Is there alternative regimens? So change from twice a day to once a day can sometimes improve adherence. And in considering add-on therapies and what add-on therapy amongst the limited options for children would be most suitable. Step 8 then is very importantly monitoring the response. So whether it's with asthma control questionnaires, lung function testing, reviewing exacerbation frequency, and school attendance to see, are the decisions or the changes that you've made, are they making an impact, or do you need to go back through step 1 to 8 again? The fact that common things are common, and asthma is common. It's probably the most common cause of chronic cough and wheeze, but it's not the only cause. And so it's just to keep it in mind, particularly if a child isn't responding well to low-dose inhaled corticosteroids. The vast majority of asthma in this age group will, and so it's got to make you think about something else going on. Some of the management issues that we have in this preschool age group are, first of all, diagnostic. They can't routinely do diagnostic lung function testing, which makes the actual diagnosis quite difficult. They get frequent respiratory viral infections, so it's hard to differentiate between what's true asthma and what's just recurrent coughs and colds that they're picking up. And obviously the children themselves may not have the vocabulary or be at a developmental age where they can describe their symptoms themselves. So symptom reports usually rely on parental observation. When it comes to treatments, we're very limited in what treatment options are available for that preschool age group. Children 2 to 5 years are rarely, if ever, included in clinical trials. We see some of the patients, well, really all the Medicaid age groups. There's one combination. You've got montelukast and you've got your chromones, and that's it in this age group. There's more research and studies into new and alternative asthma medications in this age group. It's not really for the severe asthma kids, they're really frequent wheezers. So you can see here, recent medications that are becoming available for people with severe asthma, but the children, 6 is the youngest that studies go down to. The children move into school, there's more triggers and comorbidities associated with asthma, rather than sort of just the viral induced wheeze that we see in younger kids. But we still have very limited treatment options. So we still just have that one combination ICS-LABA. There's one monoclonal antibody available in Australia, OMALIZUMAB, in this age group, and then you've got TIOTROPIUM. Triggers include allergens, so pets, dust, pollens. These kids are now in school, so they've got stresses around school. There can be the same exposures at home, so open fires, barbecues, tobacco smoke exposure. They're often now doing team sports where they're pushed that little bit harder rather than just running around the playground. They're actually outside, really pushing themselves with sports. And school itself can actually be a trigger. So we know both here in the Southern Hemisphere in February and in the Northern Hemisphere in September, in the back to school period after the summer holidays, that there is a significant increase in asthma exacerbations in children. And we're not really sure why. There's probably a combination of, during the school holidays, people are out of their normal routine, so perhaps not taking their inhalers as regularly. They don't have that normal school routine of get up, have your breakfast, do your inhaler, brush your teeth, get dressed, pack your school bag and go. So it's easy to miss out on doses. Some people, because their asthma is well controlled over summer months, they actually come off their preventers and they're advised to do so, but then don't restart them in time for going back to school. Schoolrooms are often dusty, and in places with high humidity, they might also be damp and moldy, which again, it increases the amount of allergens in the classroom. And kids have gone from being, sneezing with maybe one other person in the room to sneezing with 30 other people in the room. And so respiratory viruses circulate quite quickly in the back to school period again. So the National Asthma Council, the aiming for asthma improvement in childhood, New South Wales, Asthma Australia, all have advice, tips, and school asthma action plans, which can help with this back to school phenomenon. Moving on then to adolescents and some of the issues that this group of children face. It's a period of the most rapid growth. So obviously this is really important. This is the last chance for adolescents to reach their full adult growth, their height, minimizing on this is really so well controlled on corticosteroid. Consider certainly monitor that it isn't because of growth. There's more exam and school stress. So things like school reports and school exams do bring a lot of stress, and that can trigger asthma for a lot of adolescents. There is an increase in independence as they take over management of their own health care, usually they're taking their medications independently of their parents, apart from some reminders or pestering, but usually they are it's up to the adolescents themselves to take their medications, to remember to take them, to advise their parents when they're running low or if they're expired. But there's also a desire to fit in, and both of those things can mean that really adherence to medications and to treatments is problematic, not just in asthma, but in all chronic illnesses. These adolescents, sometimes they deny or just disregard their asthma symptoms. They try to ignore them. They sometimes avoid regular review appointments because they know they'll just be asked about, are you taking your medications, or what's your lung function like, how often are you requiring your Ventolin? There are also often emerging mental health problems in this age group, particularly depression and anxiety, both of which can impact on their asthma control and their adherence to medications. There can be more risky use of things like alcohol, cigarettes, and illegal drugs. For girls, there can be perimenstrual symptoms. So along with having to deal with all the stresses of their body changing, asthma can also flare up in and around the time of their periods, which again, if it's not asked, they won't necessarily disclose because it's not a well-known trigger, and most people it won't really occur to them that perhaps they're having these perimenstrual asthma flare-ups. And there are also communication issues, not really, it's unfair to say it's on behalf of the adolescents, but on their health providers and their parents as well, figuring out how to communicate and how to connect with adolescents can be difficult, but is important for managing their asthma. So when it comes to treatment options in severe asthma for children, look, these are the monoclonal antibodies that are available in Australia. OMALIZUMAB, mepolizumab, and benralizumab are available now, while there's lots of others are under development. And so for adults, the big dilemma is, how do you choose between them? How do you choose which patient to start on which medication? But we don't really have that luxury in pediatrics. This is the number of children which have been included worldwide in randomized controlled tests for these biological agents. So in OMALIZUMAB, we've got good data. So we've got 4 RCTs, which are purely in the 6 to 11 age group with over 800 participants. In the 12+ age group, look, I counted over 500 and then gave up because in so many studies it's 12+, including adults. So you have to go through to figure out how many actual in that 12 to 18 year age group were included, but certainly we do have a lot of data, and we also have subgroup analysis. So we know what are the effects in the school age kids, what are the effects in the adolescents separate from the adults. When it comes to mepolizumab, no children in 6 to 11 year age group. There are 2 studies which included children in the 12 to 18 group as part of an adult study, but there was no subgroup analysis, and neither report how many children or how many adolescents were included. I do have an N equals 28 from one review study, but I couldn't find from actually reading the studies myself where they came up with those. So apologies if that number isn't accurate. Benralizumab, dupilumab, and lebrikizumab, again, have no children in the school-aged age group included in the randomized controlled trials. There is about 5% in dupilumab in one dupilumab study, which included 86 kids in the 12 to 18 group, but again, no subgroup analysis to see was the results different in the younger age group compared to adults. And in benralizumab, there was 2 studies which included participants who were 12 plus, and that came to 64. So you can see in these medications where they're testing thousands of adults, the numbers of children and adolescents being tested is minimal, which makes it really difficult to know whether they're worthwhile treatments in that age group, and also whether it's something that we should be promoting. You can see here, so this is some of the baseline data you see in these studies. So you can see in the top there is a study of dupilumab, where the mean age is almost 50 years of age, and with a standard deviation of 15 years. If you've got a normal bell-shaped curve, there's not many people who are going to be, less than 5% will be in the under 18 age group. In the bottom study then, which was a mepolizumab study, they do have, again, they say they include adolescents 12 plus, but there was none in the placebo group, and there was the age range in the mepolizumab group was 16 years, so possibly they had 1 or 2 adolescents, but really they're not recruiting in children's hospitals. We do have omalizumab and mepolizumab available for children in Australia. Both require the child to have uncontrolled asthma despite being on a high-dose ICS stroke LABA combination, and having exacerbations requiring systemic steroids. Omalizumab is available from 6 years, while mepolizumab is only available for 12 years. And as you know, omalizumab, one of the criteria is a high IgE, while for mepolizumab, it's high eosinophils. Both require reversible airway obstruction on spirometry, so they have to be able to do lung function testing and either be a patient of the same physician for 6 months or part of a multidisciplinary severe asthma clinic. So that's really our 2 options, which isn't a huge amount. What do we know about the research in this space is, so in the 6 to 12-year-old kids with using omalizumab, there was one study with a follow-on open label extension. The aim of this study was to reduce the ICS dose. Interestingly, 55% of the kids in the omalizumab group withdrew completely from their ICS. So these are kids who had moderate to severe asthma. But 39% of the group who were getting placebo, monthly placebo injections, also completely withdrew from their inhaled corticosteroid, which seems bizarre. They did have more exacerbations while they were weaning than the omalizumab group, but in the 24-week open label extension, the majority of kids remained off their inhaled corticosteroid. So what this tells us really is that perhaps it's the asthma care before starting these biologics that we really need to be focusing on. So maybe it's when you look here at this table, the shaded part of the graph is the omalizumab group and the white is low. And this shows the percentage of patients who were able to reduce their steroid dose, so their inhaled corticosteroid, I think it was beclomethasone, budesonide perhaps. So 50% of the kids who were getting placebo were able to reduce their inhaled corticosteroid by 75 to 100%. So perhaps, you know, going down the route of more and more complex, more expensive medications isn't the way to go. We really need to be targeting this group who actually do really well on placebo. Mepolizumab, so like I mentioned, there's no studies in young children, the silence in adolescents, but we don't have the breakdown to see whether this is specifically in adults or whether the improvements are also relevant to adolescents. But it is associated with a reduction in oral corticosteroids, improved asthma control, and reduction in exacerbations. Is licensed in the UK, interestingly, in children from 6 years, despite having no data in that age group. And the side effects of headache really are quite frequent, but it doesn't have the same frequency of anaphylaxis that we see with OMALIZUMAB. TIOTROPIUM is another alternative in the severe asthma group, and it has recently been covered by PBS in Australia from 6 years of age. It has to be prescribed by a specialist, and it's an add-on therapy to your ICS and LABA. Studies in children, they do have studies in children which suggest that it improves your lung function, but there was some benefits on your ACQ and exacerbation rate, but they didn't meet clinical significance. Azithromycin, again, we know that the Newcastle group are doing a lot of research into azithromycin macrolide antibiotic in severe asthma. But again, the research is done in adults with very little research in children in the severe asthma group, but they are looking at in the frequent wheezers whether there's benefit. And it not just improves oral corticosteroid dosing, but also exacerbations, sputums, and symptoms. There is, if you go to the Severe Asthma Toolkit on the website, there is sort of a flow diagram that you can follow with regards to treatments when you've sort of followed the step-by-step basics of asthma assessment in children, of what are the options for add-on therapies. Oral steroids are great drugs, we know, in asthma, but terrible for side effects. And particularly in children, we need to worry about things like what effect is it having on their bone growth, their height growth, their eyes. And perhaps we're not as aware as we should be of things like stress dosing around surgery and illnesses. I think I'm going to run out of time soon. Quickly, just looking at life-threatening asthma risk factors in children. So this is from the National Asthma Council Handbook update. There's a list of risk factors which you really need to be aware of when it comes to asthma in children because of the risk of death associated with poor asthma control, recent hospitalizations, any history of intubation for severe asthma, overuse of your bronchodilator, poor adherence to preventer, poor inhaler technique or poor adherence to the asthma action plan, exposure to tobacco smoke, known allergies, and then the family-related factors, so particularly psychological and socioeconomic problems, not just amongst the child, but also amongst the parents. There was a review done in New South Wales because there had been a spike in asthma deaths in 2015. And what they found was that older boys in the 10 to 14 year age group were the highest risk of death. And 8 out of 11 of those of the deaths, there was a fax report on the child in the previous 3 years. So there was known risk of harm, which is something that should be taken into account. Overall numbers of deaths in Australia were, so nationwide are small. So you can see over a 4 year period there was 28 asthma deaths. So it's small, but the thing to consider is that many of these deaths are considered preventable or had preventable factors associated with them, and so we really need to have systems in place to make sure that people aren't slipping through the cracks. Okay.
Thank you very much, Louisa, for a tour de force there, working through all of the various issues and aspects related to managing severe asthma in a pediatrics population, as well as at all the different age groups. So that now there's time for questions here. So we had one question from the online audience so far, and that question is relating to steroid use. Do you routinely monitor for HPA suppression with children on high-dose ICS, and if so, how?
So we don't, but we should. So anyone who's on a high-dose inhaled corticosteroid should really have either an early morning cortisol or a synacthin test done. I don't think it's routine certainly in the majority of clinics, so it's probably something that gets missed, but it should be higher on people's radar.
And Louisa, so you asked, or you discussed kind of the management plan and treatment strategy for the most part after referral, or in the cases of when you are helping with management for these children. From your perspective, what can you say regarding referrals to specialist care? Is it happening frequently enough? Too frequently? Is this something that should be flagged?
I think it's probably not happening enough, and it doesn't have to be a respiratory pediatrician. So, you know, most general pediatricians are also quite experienced in management of asthma. But yeah, I mean, time and time again, we see children who have been just managed by their GP, not necessarily following guidelines, and they're really struggling both with symptoms, school, missing time off school, being told they can't do sports, and it's often, you know, not a hugely complex issue, but it just needs asthma education and support, and being linked in with a respiratory clinic. You usually get access to things like nurse support, and the nurse can contact the school and sort of build up the supports around the child.
Excellent. Is there any more questions? You're in Newcastle. We had another question from the online audience. Would you use an inhaled corticosteroid alert card or similar?
No, we don't actually, and I haven't seen any available. So this is, I presume, for stress dosing if a child was to become unwell. But no, it's a good idea.
Excellent. Well, thank you very much, Louisa, for an excellent presentation, and thank you to the audience for joining us. I hope you found this presentation useful for your practice, and thank you for attending.
Thank you, Steve.